Welcome, SLP215. All right. Oh, one more. All right, neurogenic disorders. Okay, just some questions from last week. So, right hemisphere disorder. A couple people asked, were those real or were those mock? You know what? I'm not exactly sure. I think one or two was real and one was mock. And I'm almost sure one for sure was a mock one. So a couple of people had asked that question. It's really hard. Like I said, that's probably the most underdiagnosed disorder. So definitely, I mean, they are diagnosed. You will see them, but not as often as you will other kinds of aphasia. Okay, so neurogenic. So let's talk about that. Neurogenic speech disorders. And this is kind of more global. So when we're talking about neurogenic, I just want to say what we're really talking about. And I apologize. I sit on this like swiggle bouncy chair. And I was watching one of the videos. I was like, oh gosh, I apologize if anybody gets motion sickness watching me teach. I just noticed that I really was really bad about that. Sorry, I was just watching a video earlier today and I was like, gosh, I didn't quit moving. Okay, sorry, got sidetracked. All right, ALS. So when we're talking about neurogenic, a lot of times we're talking about Parkinson's, ALS, MS, any kind of degenerative disease that affects your brain. Another one too, I feel like we see more of the physical things first, but you know, the various types of muscular dystrophies, and there's a lot, and it, you know, affects your brain differently. But anytime you've got like that motor neuron impairment, that also is part of, you know, definitely some issues with your brain too. So let's look at, what's this one? Oh, Huntington's disease. I was like, there's another one. So that's an inherited disease. Usually people are prepared for it. So Huntington's, Parkinson's, ALS is the other one. So an ALS is rough in that it's progressive, and there are some newer promising support for it, but definitely, so you can kind of look through this if you're not familiar with it, and kind of gives you some understanding of how does it affect you. So when you look at kind of the stages, so a lot of times in therapy, you might see somebody with ALS kind of at different stages of this disease because they might need different interventions. So anytime, and Parkinson's is the other big one. So many times we see issues with eating. So swallowing is a big one. But what I want to say is for you guys as an SLPA, we might just be working on compensatory strategies that are helpful for them at the moment, but might not be later on down the road. So a lot of times with ALS, we're working on augmentative communication, something that they can easily do when they start to lose the ability to talk. Parkinson's is another one. A lot of times too, they're taking medication. So there's things that are managed, things that aren't, and it's a lot of compensatory things. So when we're looking at any kind of progressive neurological disease, for us as therapists, we're not going to necessarily ever improve it. What we're going to do is help them learn compensatory strategies to support their communication, daily living, etc., as it progresses. So usually, like I said, there's different things we do at different times. And there is a lot of eating things too that we also do. So you guys as SLPs may not do that, but your supervisor might. The other part that really I think is hard in a therapy perspective is we got to support their communication support group. So is that their family? Is that their parents? Is that their spouse? Is that their adult grown children? And again, people are diagnosed with these at different ages. So what I like about this particular website really kind of goes through the prevalences and characteristics of speech disorders. So neurogenic speech disorder. So if you hear that, a lot of times too, sometimes we don't know what the disease is. So there's a lot of things that kind of have more what I call a blanket general term. We just know it's progressive neurological disease. They may not have a name for it quite yet. And usually we're seeing clients at various stages of their diagnosis. So sometimes they think, you might just be having an issue. So for instance, I had a client, and he was young, and I say young, I mean, he was an adult, but he was, I don't know, late 20s. And all of a sudden he was talking about difficulty with swallowing. And he came into the clinic at the rehab hospital, outpatient where I worked. And, he was talking about this, these difficulties, which was really odd. He didn't have any kind of other injury that would give us an indication he would have those difficulties. And, so his primary care sent him to speech. Well, let's work on your swallowing. Maybe just, and then we go through all the diagnostic processes and stuff. And then I worked with him. I did about 10 sessions with him in between some of his testing with other professionals. And he had some kind of rare disorder. I wish I could remember the name of it, that I had never heard of. My supervisor at the time at the rehab hospital, he hadn't heard of it either. And we weren't real sure what to expect, but things changed for him in the year and a half I saw him quickly. So definitely we were constantly doing some compensatory things, as well as working with his support system to support him. So kind of, you can look through this speech communication, more general things. Dysarthria, apraxia definitely can happen with any of the neurogenic disorders, as well as, ataxic. We see sometimes whole body things. And that's usually, kind of we'll see more global gross motor things first, usually, before we see all of the other things related to speech. So typically, a lot of times too, before people go into invasive testing or costly testing, they go to therapy first. And then in the meantime, so anytime you're seeing anybody and you suspect more things are going on, or you've seen drastic change from somebody, definitely that's something you need to alert your supervisor to, because this might be where us as your supervisor need to be referring this client to other professionals, or really saying, hey, this isn't working. This isn't just relearning a skill. This isn't just some little hiccup they had. This is something, possibly bigger. So definitely some things that just for your awareness, not that you ever have to diagnose yourself, but when should you be alerting your supervisor to things? So perfect example. And I had never had a client with ALS until I worked at a school. So at the rehab hospital, I didn't encounter anybody. I had like, Guillain-Barré, MS. I had not ALS, but the Parkinson's. So Huntington's, I had a couple people with Huntington's. So ALS was newer. I mean, obviously I knew it existed, but for instance, my SLPA was working with a student at the high school, and she just reported some things she thought was odd. So like the client also, or a student, all of a sudden it seems like she couldn't type, and typing was never a problem for her before. So when she was working on some of her English stuff, it's like she really struggled to type, and that wasn't like her. And seems that she was getting confused at times, or all of a sudden one day she was lost in the hallway. So just some random observation, my SLPA let me know. And then as we kind of got into it, really looking at some of the changes. And I happen to know this particular student since she was a kindergartner. I had her, that long. She was a sophomore now. And, all of a sudden she started walking with a limp, but she didn't have any kind of, injury that would necessitate her limping. I had the physical therapist, so I referred, I told the PT, I was like, hey, can you check her out? This seemed weird. I had talked to the mom. I was like, yeah, I don't know. This just kind of started. Have her in to see the orthopedic, but that's 6 weeks out. And the physical therapist came to see me. She's like, I don't know what's going on, but I have a really bad feeling that is not typical. That's not an injury. That seems more neurological based. And then I was telling her about the hands. I had the occupational therapist come check her out. And this girl, it was quick. So she ended up having ALS, which was rare because she was so young. And it was like a span of 8 months. It went quick. And, she got diagnosed in May, and then she passed away in December. So it was really, really, really fast and incredibly progressive. So, and we were on it right away. And still, I felt like, that family was really blindsided. As well as the doctors were shocked too, because we hadn't seen, something. But she was part of her parents donated her body to the ALS research group. And so, they're trying to figure out what happened, because definitely progressive. But I just hadn't seen that in a young person. So even we wouldn't predict something neurological that invasive with a young adolescent. But anytime you see anything like that, and the other thing too is muscular dystrophy. So a lot of times that isn't diagnosed right away, or they don't know about it. They don't know it's, not all of them are family inherited. Some of them are, but not all of them. So sometimes they don't get that diagnosis till 10 or 12. And a lot of times one of our first things we see is deterioration of speech. So, they were doing fine, or they were in speech, and all of a sudden now we see a big change in their ability to produce sounds, which is not normal. So some of those things, just be aware, hey, this is weird. I need to tell my supervisor. Like I said, usually with neurogenic, we might treat speech, but if it's progressive, we might work on some compensatory strategies, especially with Parkinson's. There's some different therapies they do with Parkinson's. And it depends on how fast things are progressing and what are their, medications they're taking, and, what is their daily life like. So sometimes people, if you look at what's the actor, Michael J. Fox, right? He has Parkinson's, he's had it for a long time, but, his is different than maybe somebody else getting a diagnosis later. So definitely there are some improvements in our medical science that are supporting these people who have these progressive diseases. So be aware of that. Let me go through a couple of these slides. Yeah. Okay. So dementia. Dementia is also kind of what I call the blanket term. Definitely progressive. And do we treat people with dementia? We do. But a lot of times it's about setting up their environment so that they're safe, working on some of those daily living things. Brain tumor is another one. So yeah, so if you're not familiar with Parkinson's, ALS, be sure you're up to speed on what those are. Those are kind of the most common. MS, Huntington's. Okay, so dementia. I feel like we kind of just use that as a general term. Alzheimer's is obviously the most common cause of dementia, but just because somebody has dementia doesn't mean they have Alzheimer's. So definitely there's some differential diagnoses that doctors go through, but a lot of times we'll get a referral and it's dementia. Okay, and someone's asked, so what do we do? A lot of times what we're doing is working on compensatory skills. Or they're at a point, for instance, they might just have some subtle signs of dementia. Okay, what are some things we can help this person with? How can we set up a safety net? It's a lot of checks and balances. And sometimes that might also be done with the occupational therapist. A lot of times we're looking at like safety in their home. How are they going to go about their daily living activities? So brain tumor, definitely some neurological challenges there. I have had quite a few with the brain tumor, and there is a brain tumor that people have that where it just keeps growing. They take it out, but it kind of reoccurs. It's not necessarily cancerous, but it does keep coming back, and it affects the brain in various ways. And then if they have to go through radiation, those kinds of things to shrink it, or brain surgery to remove it, definitely some challenges with communication. Then they might also have some characteristics of aphasia. Executive functioning can be dramatically impaired with anybody who has experienced a brain tumor, and depending on where it is, or if it's in the language center, they can have difficulty. If it's in the cerebellum, definitely some more motor issues. And then common speech and language needs. So a lot of times they have the actual speech production difficulties, and definitely dysarthria for sure. And then also dysphagia, then language. So word finding, we definitely see that in these progressive neurological cases. Word finding seems to be the first sign that we see. And then language organization, cognition, and then also the ability to retell information. So that narrative language piece, those are kind of the key things in language that we see. And then really kind of functional. So a lot of times with the progressive disorders, we're working on helping them learn alternative modes of communication, and then executive function. So definitely we see impairments along various levels in various ways within their day. And that's where a lot of times when we're doing therapy, so you guys as SLPAs, a lot of times we're doing home health, and we're working at home and working with their family and supporting the client. So lots of different ways therapy can go when we're working with somebody with a progressive neurological disease. So other big key piece is teaming. Likely you're not going to be by yourself. You're going to be working with other professionals in more of a team manner. So we might be responsible, and I say we, you and your supervisor. Speech is working on this component, where OT is working on that component, and physical therapy is working on, safety measures in the home. And then obviously then there's the medical piece, there's medical management, family and environmental support. So truly, not that it's not important in all the other disorders, it is. But truly, when we're working with somebody who has something that's progressive, oh boy, I hate when that gives me that notice. Hopefully it's not fuzzy. We're working with the family to support them, because a lot of times they start with no impairments. And the family's used to this person not having these impairments, not having these challenges. So it's a big adjustment for the family versus, a child who have maybe always had these difficulties. When we're talking about adult, which many of our clients with progressive neurological disorders are adults, there's a dramatic change with that dynamic, with their role, with their place within the family. So definitely a lot of support for the family and the environment, as well as our focus in therapy might change. And a lot of times we might, especially when you're dealing with like insurance coverage, that kind of thing, you might do 12 sessions this year. And then the following year you come back, you visit the client, you're going to do another 12 to 15 and work on another thing. So a lot of times you see these people repeated. You do some short-term therapy with them, and then they come back for the next change. So it's usually a lot of times not a continuous stream of therapy. It's kind of, they need about 10, 15, 20 sessions here. And then about 9, 10 months, a year, 2 years, they need another big bulk. And then now we're not doing outpatient, now we do home health. So a lot of times too, where you're providing services might also change. And a lot of times these people also end up in a skilled nursing facility because you know, their whole systems have deteriorated and they require 24-hour medical care. And a lot of times at that point, you're not necessarily doing direct, you're doing more of consultative things. So definitely things change for them. Whereas you usually hope you do therapy for them, they get better, boom, you don't need to see them again. And that's what's, I think, challenging for the progressive neurological diseases is things aren't improving, things aren't going to get better. And I think there's a different mindset when we know things are going to get worse. So that's kind of a different edge. Therapy is usually for improvement. And here we're just looking to try to maintain quality of life or quality of functioning, independence, those kinds of things. So definitely kind of the focus of therapy is definitely different with our group with the progressive neurogenic disorders for sure. So like I said, that's a different mindset from a therapy perspective. So this week we have a neurogenic speech disorder observation, a short assessment, and then a read and review summary. So should not be too bad this week. If you guys do need more time, hopefully everybody's enjoying their Thanksgiving, being safe, staying healthy. But again, I know there's a lot going on this week and maybe people's plans and things changed dramatically too. So just let me know if you do need more time. I always give more time this week if you need it. Just let me know ahead of time. I'll be happy to give you some extra time. But other than that, I hope everybody's enjoying their Thanksgiving and staying healthy. Almost done, guys. 2 more weeks. Yay. Oh, really? 2.5. Just under 3 weeks. That's it. Oh, the assessment, vocab, and the different disorders. So what should you focus on the assessment? Definitely look at the vocabulary and what are some of the targets that we use? What are some of the things we might do in therapy for somebody who has a progressive neurological disease? Real general. I'm not asking for anything too specific.